This session is about mental health and well-being, and it gives me great pleasure to chair the session. We're going to start with, thank goodness, Gary Chueng in the room. Gary needs no introduction. He's been chairing us for the morning, and he's going to give a presentation written by Etu Ma'u, who's also is a very well-known researcher and a senior lecturer in the Department of Psychological Medicine. And it's about psychological distress, self-reported diagnosis of mental disorders, and risk of dementia, incident dementia.
So Etu sends his apology. He can't be here today because of a personal reason. And here's the slide. Good. So Etu is a senior lecturer in our department. This is part of his PhD, looking at the risk of dementia and also the prevention of dementia. So I'm one of his PhD supervisors, and I have read this paper. I think this paper is currently under review. Self-reported diagnosis of mental disorders, psychological distress, and risk of incident dementia in New Zealand. So for those dementia researchers in the room, you should be familiar with the Livingstone risk factors for dementia on your left. The diagram there show 14 risk factors. So Jill Livingstone and her team updated the number of risk factors from 12 to 14 last year, and that was launched in the AAIC conference in Toronto. I remember that because I was there. Not Toronto, Philadelphia. This year is going to be Toronto for those who's going. So 14 risk factors, and among those risk factors, you probably can see there, risk factors such as obesity, smoking, alcohol use, low education, and so on. And of course, depression is there because we're talking about risk factors of mental disorder. So it's recognized as a risk factors for dementia. In the Lancet Commission, they also look at prevent and delay dementia. And these are the 4 plausible biological mechanisms that can lead to prevention and delay of dementia. So these biological mechanisms include decreased vascular damage, reduced dementia neuropathology, reduced stress on the brain and inflammation, and building cognitive and brain reserve. So those are the 14 risk factors well recognized. They also talked about these potential candidates. So these are sleep, diet, infections, menopause, and a bunch of psychiatric disorders, bipolar disorder, anxiety, PTSD, psychosis, and schizophrenia. Because we know psychiatric disorders can cause stress, of course, and can cause the chronic stress and also inflammation of the brain. So these are potential candidates, and we just need more information to build up the evidence. So that's part of the reason Etu decided to do his study on this, is to build more information. So this is the risk. This is the Livingstone, the Lancet Commission. If you look at the depression, the relative risk for developing dementia is 2.2, so double the risk if you have a history of depression. And the earlier onset of the depression, so 18 to 4 years old, if you have depression during that life stage, the risk is about 3 times relative risk. Where if you're older, 60 plus, still a risk, is a lower risk. So 2 to 3 times higher. Anxiety, the result for, that's why it's potential candidate, because if you look at this systematic review, the relative risk is 1.18, but look at the confidence interval, it's cross 1, so it's not strong enough. But this is one of the systematic reviews done on anxiety. Bipolar disorder, another systematic review. Again, earlier age of onset, longer duration and severity have higher risk of developing dementia. So these are all overseas data. There is a New Zealand longitudinal study look at hospital diagnosis of psychiatric disorder. These are the psychiatric disorder they look at, and I want to emphasize these are hospital diagnoses. So these are probably quite severe diagnoses because mental health service only see the top, we're supposed to see the top 3% of people with mental disorders. So any mental disorder, the risk is high, isn't it? 4, and mood disorders there, psychotic disorder 6 times. It's quite high, isn't it? Psychological distress itself, so this is not psychiatric disorders or mental disorder. So this is psychological stress. There is also evidence that in itself can increase the risk of dementia. So this is Etu's aims to estimate the incident dementia risk associated with depression, anxiety, and bipolar disorder. And the second aim is to explore the association between psychological distress and dementia. So Etu used the New Zealand Health Survey as the cohort, and it's a retrospective cohort study. So look at people in the New Zealand Health Survey and then follow them up over a period of average of 6 years. And in the New Zealand Health Survey, if you're familiar with them, they ask questions about self-report depression, bipolar disorder, or any anxiety disorder. So it's a good annual health survey by, I don't know who does that, must be Statistics New Zealand. And also they also do the Kessler psychological distress scale. Kessler is commonly used, particularly in primary care. So if you score less than 20, that means your psychological distress is within the normal range. If it's higher than 20, depending on the score, range from mild, moderate to severe. So this is the method, the New Zealand Health Survey, and over a period of 6 or 7 years, annual survey, and capture just over 74,000 people who had that annual survey. Follow them up, mean duration 6 years, and they find people have dementia and no dementia. So I actually updated the slide because Etu didn't put the percentage. So the percentage of people develop dementia is 2.6%. My laptop is not working, so I can't send the slide to Karen. But anyway, it's 2.6%. How do we define dementia? This is quite a well-established method now. We started this using these 7 routinely collected health data sets. interRAI, of course, interRAI, that's why we're here. Mortality, Socrates, pharmaceutical, private hospital, public hospital discharge, and prime data. That's the mental health data. But like Christian's study, you also use, I think you use interRAI, pharmaceutical, and hospital discharges. And the reason behind that is those 3 data sets capture the most number of dementia diagnoses. In fact, interRAI is the winner. 62% of all dementia cases in routinely collected health data sets, you can find them on interRAI. So good. The cohort characteristics, again, I tried to update the slide yesterday. The percentage underneath in the dementia column is actually not right. I don't think we got the denominator or nominator correct. But the distribution of the age, gender, and ethnicity pretty much the same across the 2 groups, people, the total cohort, and also people with dementia. So I'll quickly move to the next one. These percentages are right, actually. So if you look at people with dementia, ever diagnosed with depression, it's about 17.7%. Compared to the total population, 19.1. You see bipolars, 1.4, 1.5%. That's the right, actually, because if we read psychiatric textbook, we talk about 1% of the population has a diagnosis of bipolar disorder. Anxiety disorder is there. And then the Kessler scales, people less than 20, that's within the normal range. So most people were within the normal range, so 80% or so. So this is the result. So people with self-reported mental health disorders. So Etu fitted the data to using two models. The model one is unadjusted. So you've all heard about adjusted analysis this morning from John. And model two is adjusted. What do we adjust it for? Some of those risk factors Livingstone talked about, cardiovascular risk factors, because those themselves can lead to higher risk of dementia. So things like hypertension, smoking, obesity, all those risk factors gets adjusted. What did he find? There's a higher risk, basically, for depression, just over 1.4, a little bit higher for bipolar, anxiety a bit lower, but like the numbers I show you from international literature, actually, and then any mental health disorder around about 1.3, 1.4. That suddenly appeared. Okay. If you look at, so yes, that's the study confirmed mental disorder, depression, bipolar, and anxiety have a higher risk of incident dementia. And then when we look at psychological distress, you see a similar sort of increase in risk in two models, model one and model two, both have increased risks of dementia. So stress is not good for us. Kind of know that, don't we? Not good for our brain. So the discussion just have to, the duration follow-up only 6 years. So if we have followed the group longer, we probably see more people with dementia because age is a main risk factor. So some people argue self-reported mental health diagnosis, is that valid? But this a body of literature suggests that is valid. If you, particular bipolar disorder, potential psychotropic medication, we didn't adjust for that because there's a body of literature saying psychotropic medication can be associated with dementia. So that's, had to disentangle things like benzodiazepine, antipsychotic medications. They can cause cognitive impairment as well. So in this study, we didn't adjust for those pharmaceutical agents. And this is a cross-sectional association of psychological distress and dementia, just one-off, because the health survey is annual, and every year they have different 10,000 or so people completed that. So it's a cross-sectional with a future study can, look at a more longitudinal relationship between the distress and dementia. So acknowledgement. That's something didn't come. Sally Cullum, associate professor in our department, also one of the supervisors, and also Jill and he from University College London collaborate on this project. Thank you.
So my understanding is that these are correlations, right? We don't yet have evidence that they're causal. If I got that right? Yeah. And so how do we go picking that apart? Do you know? Do you have ideas?
I think like any other dementia risk factors, isn't it? It's a combination of risk factors usually. We can't just say one risk factor caused dementia. Yeah. And even with Alzheimer's disease, it's different pathway that can result in those accumulating plaques and tangles. We have the hypothesis, but there's different pathway that can lead to that. Yeah, so I imagine there's different risk factors, and you can do everything right or do everything wrong and you won't get dementia, isn't it? If you do everything right, some people still get dementia. Yeah. But at a population level, if we look at prevention, so if we target, say, how to reduce stress at a population level, that will bring the relative risk down, and the number of people with dementia in that population can reduce, and then might save the money and all that. Yeah.
I am intrigued because it's Nairi here, Nairi Kerr. So I'm intrigued that we read Jill Livingstone's paper and the extension of it. And it really is a population attributable risk. And so the messages are for public health. And yet many of the clinicians in the room, and myself included, try to make it into a personal risk and personal intervention strategy. Is that a good idea, Gary, or is it wasting time?
No, I think you need a different approach. So at a personal level, you probably look at machine learning that can predict that person's risk. Again, it's a risk. So the risk may be 60% you will develop dementia. It's never 100%, isn't it? But 60%, if I, in 10 years' time, 60%, probably I'm higher than Nari, say 40%. So if I'm higher at risk, can I do something now to do more brain health, focus on brain health and stop smoking, drinking, address my obesity? That may reduce the risk.